getting settled and getting some of the housekeeping items out of the way. If you're just joining us, we invite you to introduce yourself to your colleagues in the chat. So you'll see a little kind of speech bubble that says chat. So please feel free to introduce yourself and your role and your practice or program name so we can get to know each other as we use the chat as a discussion forum throughout our hour together. We appreciate you being with us this afternoon. I'm going to briefly just introduce this webinar today and our series, and then I'm going to turn it over to our guest, Dr. Fishman. We're grateful to have him with us this afternoon. For those of you who might be joining us today for the first time, I'm Kelly Koval. I'm the program director. I have the privilege of being the program director for both Maryland BHIPP and MACS, Maryland Addiction Consultation Service. And I think this is our first time that we have done a mashup, kind of a webinar, bringing together both programs. We're excited to be doing this today and hope it's not the last time that we do this. Dr. Fishman, do you mind advancing to the next slide? So we're talking today about youth and substances. Oh, I'm sorry, it's here, Dr. Fishman. What's a primary care provider to do? And Dr. Fishman is going to take us through this discussion today. And this is part of our focus this month in September, celebrating Recovery Month. So if you follow along with either MACS or Maryland BHIPP on social media, or you subscribe to our newsletters, you will see that we've been featuring content, webinars, or other items related to Recovery Month throughout September. And it's certainly something that we discuss throughout the year, thinking about how you support your patients related to substance use or substance use disorders. So I will prepare to turn this over to Dr. Fishman, but I want to give him a warm welcome from both the MACS and BHIPP teams, and I will briefly introduce him and then let him take it away. So Dr. Fishman is an addiction psychiatrist. He's the medical director of Maryland Treatment Centers and a member of the psychiatry faculty of the Johns Hopkins University School of Medicine. Dr. Fishman leads Maryland Treatment Centers, a regional behavioral health care provider, which includes Mountain Manor Treatment Centers in Baltimore and Emmitsburg, as well as several other inpatient and outpatient programs. In that role, he has been involved in development and implementation of innovative programming in addiction and co-occurring disorder treatment. His clinical specialties include treatment of drug-involved and dual diagnosis youth, opioid addiction in adolescents and adults, and addiction with co-occurring psychiatric disorders. His research work has focused on medication treatment for SUDs, as well as models of care and treatment outcomes in youth, in particular opioid addiction. He has been a president of the Maryland Society of Addiction Medicine and is currently a member of its board. We are really grateful to have Dr. Fishman here with us as we are wrapping up Recovery Month as September closes, and as I mentioned, for this first joint webinar for MACS and Maryland BHIPP. So Dr. Fishman, thank you again, and we look forward to hearing you over this next hour.
Well, great. Thank you for that warm welcome. It's nice to be here. Thanks, everyone, for joining us for a brief bit. I'm going to try to pack a lot in, so this is an outline of our Whirlwinds tour today, thinking about how non-specialists might think about and act on and intervene with young people who use substances, thinking about assessment, thinking about how to do brief interventions, thinking about how to involve and communicate with parents, thinking about how to make referrals to specialists. And to start out, I'm going to talk a little bit about the scope of the problem, that is some epidemiology use patterns, and talk about the background of developmental vulnerability. And I'm going to highlight along the way a couple of important topics, not that they're the only important substances that youth get into, but they're certainly very topical, talking about cannabis, because according to the kids, right, cannabis isn't a drug, but we know different. And so I want to talk just a little bit about some points of knowledge, maybe you all know them already, about why we're concerned about young people with cannabis, and then talk a little bit about opioids because of how dangerous they are, and about the current epidemic that includes overdose and, of course, catastrophic premature death. So just to get into scope and background, there is this divide. By the way, when we talk about youth, I mean both adolescents and young adults. If you guys work with young people, you know that it isn't any bright line of a particular age. That a person's 18th birthday, suddenly they're all grown up, and then that's the end of the developmental period of being an adolescent or being a youth. In Brooklyn, we call, or not me, but in Brooklyn they call them youths, right? But the idea is it's a developmental period. It's about maturation or immaturation. It's about developmental vulnerability. Some people might say that adolescence for some goes into the 30s. I don't know, but somewhere in that range, 13 to 25, 26. And this idea of a generation gap or a divide between the perspective of us as adults, me as an old guy, graybeard, and young people, it's important for us to think a little bit about where that puts us in terms of perspective. Certainly, we see in young people promise and opportunity and resilience and emerging independence and excitement, but we also see immaturity and risk. And we forget, I mean, most of us in this room have either worked with teenagers or parented teenagers, or maybe some of us have even been teenagers, I don't know. But it looks like a long time ago, right? And it's easy to lose perspective of our thinking that just because we can give advice, so it should be so, and all will follow along merrily, if only they would do what we say, darn it. So I just wanted to give you this quote and give a historical perspective. We live in a decadent age. Young people no longer respect their parents. They are rude and impatient, frequent taverns, and have no self-respect. Right? We've heard that before. You may have even said that. I've certainly said it. But look, this was from an inscription on an Egyptian tomb in 3000 BC. So this kind of thing's been going on for a long time, just to give you that perspective, and we have to be careful. So here is looking at U.S. 12th graders reporting lifetime substance use of a variety of substances, just to give you a sense of the scope of the problem currently, cross-sectionally, but also historically over time. And you can see that they rank in terms of which substances are most used. Not surprising, alcohol is number one, and there has been a decrease over time in recent decades in alcohol use. That's good news, although still at high rates. Cannabis, relatively stable. Tobacco decreasing considerably, and that's one of the great public health victories, perhaps, of the last 3/4 of a century, both in young people and adults. And then other illicit drugs, much lower behind that. And there's a couple of messages that I think are important here. When you talk about using substances, we certainly know that experimentation with substance use and other risk behaviors, sexual risk behaviors, riding a bicycle without a helmet, whatever, are normative features of the behaviors of teenagers and young adults. They will get into mischief and they will skin their knees, and we expect that. And so we don't want to be prudish, but on the other hand, we want to caution against the risk behaviors for not moral reasons, but for reasons of health and improvement of psychosocial function. You'll hear me say that again and again. We want to frame this in a health messaging paradigm. But when you talk to youth and their families about substance use and why it's a problem, one of the first things you'll hear is, well, everybody does it. And I want to caution you that that's not what the data tells us. Yeah, a lot of people are using, but not everybody is using. So look at the alcohol line. Currently in the area of 60% of youth have had lifetime alcohol experience. Well, that's a lot, but it's not everyone. And you can subsume all the other lines in there because all the people who've used the others have also used alcohol. So that's really a marker, if you will, or a proxy for use of any substance. But if 60% of 12th graders-ish have used lifetime alcohol, nicotine, or cannabis or other drugs, remember that means that 40% have not. Now, when I say it that way, isn't that a little surprising? People say everybody's doing it. Everybody. Well, not everybody. 40% of youth have never, of 12th graders, have never in their lifetime used alcohol, cannabis, tobacco, or other drugs. So again, it's the minority, but it's a very substantial minority, and that number is growing over time. So that's a message of optimism. As problematic, and we're going to talk about what the problems are, as problematic as substance use and then progression to substance use disorder and full addiction is in young people, it isn't everybody. And so when people say everybody, well, maybe everybody you know, and right in there is aggregation of deviant peers for sure, but it isn't true of everybody. And so it's important to make that social norming message. All right, so here's binge drinking. So we see that, and binge drinking we typically define as 5 or more alcoholic drinks in a session or in a day. For males, 4. For females, that's a body weight issue. And you can see the numbers. The numbers are falling historically, so that's good news. But there are still considerable numbers of 12th graders, 10th graders, and 8th graders who have a binge drinking pattern. And this is in the past 2 weeks. So this is a marker of current problem binge drinking, right? Now, let's talk about developmental vulnerability. This is looking at prevalence rates of use of these 5 substances over the lifespan. And you can see for these substances, alcohol, tobacco, binge alcohol, any illicit drug use, and cannabis, that the shape is relatively similar, although the magnitude might be different. And again, the highest magnitude is alcohol, as we saw before. But the ascending limb of the curve is on the left. That is, this is a problem of pediatric onset in the 2nd decade of life, right? So take that point for a second. I want us to think about substance use disorder and addiction writ large as a pediatric problem, a developmental problem of pediatric origin. And it peaks at the end of the 2nd decade of life, beginning of 3rd decade of life, right? And you'll notice that it is not a linear scale. We've blown up the left. Not that plenty of people aren't using on the right hand of the scale later on in the lifespan, but we've blown up the left because that's where the action is. It's the ascending limb of the curve. We see peak around the age of 21, and plenty of people are using on the right-hand side of the curve, but they started when they were young. Here's another view of that, looking at markers of severity, markers of problem status in adults stratified by age of onset of these 3 substances, tobacco, alcohol, and cannabis, right? And you can see that we're talking about stratification in very narrow windows, under 14, between 15 and 17, and over 17, and just 3 years of development, right? And teens are changing fast. Development is happening at an accelerated rate. That's not news to you. But those narrow windows of change confer a great deal of impact. And looking across, you see that the difference between below 14 and over 17 in terms of onset confers between a 2 times and an 8-fold difference in having a problem as an adult. And if you look at the light blue across the top, onset before the age of 14 confers a 25% risk of problems with any of these 3 substances as an adult. So it's very significant. Development matters. And it's of considerable interest to think about, well, what's inside that black box? Here's another view looking at age of onset in terms of outcome for problem substance use. And we're looking at percent still using. So this is a survival curve of non-relapse, looking at the number of years from first use to 1 or more years of abstinence in the community. That's one kind of marker of success. And we've stratified into 3 groups: onset under 15, onset between 15 and 20, and onset of 20 at 21 plus. And the difference between onset under 15 and delay of onset till over 21, look at the median at 50% across the middle, confers a 60% worsening. That is 60% longer the stability in the community. The younger they start, the longer they use. So you guys know about young people, but just to briefly summarize, earlier confers worse prognosis. We said that. And all of these kinds of elements of immaturity during what we know to be a critical development period confer vulnerability. adolescents and young people are more impulsive, more excitement-seeking. They have more difficulty delaying gratification. They have poor executive function and inhibitory control. They have more difficulties with emotion regulation. And I'll show you just a few highlighted examples of some of those features as to talk about mechanism. This graphic here is a picture of myelination over the lifespan through young adulthood, just to make the point that we can not only describe these in psychological terms and behavioral terms, but we can also see some of the effects or causes, but some of the markers in morphological and structural changes in brain function as well. So many of you may know about this important body of work by Walter Mischel at Stanford, now 3 decades ago, in looking at executive control and inhibitory control in young people, a Stanford Marshmallow experiment. And if I can get the video to work, I just want to show you an example of what that looks like in a kind of colorful, silly, but fun video that illustrates the paradigm of temptation and its resistance. Now, this is going to be for 5- and 6-year-olds with the temptation of, do I eat a sweet marshmallow or not? Or can I resist that temptation? Can I postpone that gratification? But I want you to be thinking by analogy to fast forward to youth confronted with the temptation to use intoxicating substances or not as a paradigm of temptation and the ability or not to postpone gratification and resist temptation. So let's see if we can get this to go. It's not letting me do it. Because I'm not technologically sophisticated enough to do this. It's right, it's not on my machine now, it's embedded in the Cisco WebEx. All right, so we'll skip it, but I urge you, if you don't know about this, take a look. You can see this on YouTube. It's a hoot. They're very cute. The idea is that the evil, torturesome experimenter brings these 5- or 6-year-olds in the room and says to them, you can eat this marshmallow now, but try not to eat it for 5 minutes, and I'll come back in 5 minutes, and if you haven't eaten it, I'll give you 2. So we're setting as the aspiration to try to resist the temptation, and some can do it and some cannot. And you can measure outcomes. And anyway, what's funny about it is to see these poor little kids. They're struggling, and they're so transparent, and you can see it in their faces. I want to, but I won't. Oh, I'll sniff it. Oh, no, but I can't. Oh, I'll take a little nibble. No one will notice. That doesn't really count as eating. Some of them just eat it right away and don't even care. Others have to control and distract themselves, and you can see kind of it sitting on their hands or tapping their feet. In any case, the notion is that this work has now been replicated again and again in every country, in every culture, in every race, in every socioeconomic setting. And we've learned a great deal about what the predictors of poor inhibitory control mean and the footprint of what it means to have poor inhibitory executive function control is really quite remarkable. So, and you can measure it either by latency to eating or binary, you eat it or you don't eat it, various ways to skin the cat to cut the statistics. But essentially, having executive inhibitory control and not eating the marshmallow at age 5 or 6 is correlated with academic performance in elementary, middle, high school graduation rates, college entry rates, college GPA, college graduation rates, adulthood employment, onset and prevalence of substance use disorder, adult salary, adult marital rates, and adult subjective ratings of happiness. A lot of stuff. Now, I don't mean to overstate it or exaggerate it or to be overdramatic. It is not 100%. You take one nibble of the marshmallow and you're doomed. Of course not. Change happens, maturation happens, life instruction, and people grow in all sorts of ways, trajectories change. But this correlation is very, very instructive. And let's drill down for a second on the substance use issue. Again, thinking of a teenager and the ubiquitous temptation for intoxication and the ability to postpone, and there's heterogeneity in the population. in general, teenagers have lower capacity for executive function and inhibitory control than adults, so they are more vulnerable. And those that are on the bell curve, lower part of the bell curve spectrum of vulnerability, have greater difficulty than those that are on the greater side of the bell curve. Now I want to show you another example of executive function. Quick, tell me what the color is in the upper left-hand corner. Right? And you can see that you are tempted to say yellow when the color is actually orange, right? This is called the Stroop test, invented by the evil Dr. Stroop. I'm sure you may have seen it before. It's one among dozens of tests of executive function, and it's a two-signal interference and impulse inhibition test, right? You've got two different signals with contradictory information, the color itself and the verbal cue for the color, and you have to slow down, not blurt the first thing that comes into your mind, think about what the instruction set is, exert inhibitory control, right? And again, by analogy, think about what this means in terms of resisting temptation in the environment, right? Young people, adolescents, young adults who are not fully mature, who do not have fully developed brains, don't have as good performance on this and other tests of executive function as adults. People with substance use don't do as well as people without substance use, and there is heterogeneity in the population about high executive function and lower executive function, and all of these things confer risk. Emotion regulation and dysregulation are common. You'll hear lots of parents of teenagers and young adults that have troubles both with substances, with comorbid psychiatric disorders, and behavioral dysregulation say, you know, my kid has always had this trouble. Of my 4 kids, this was the one who was always into mischief. This was the one that had tantrums. This was the one that didn't sleep well. This was the one that couldn't self-regulate. This was the one who always had his hand in the cookie jar. Again, I'm exaggerating to make it sound simple, but the idea is there are intersecting vulnerabilities that we think have to do with maturation, immaturation, and these themes of emotional dysregulation and executive inhibitory control, which are related to substance use disorders as well as other behavioral risk behaviors that tend to overlap and have to do and overlap with things like poor frustration tolerance, irritability and anger, overreactivity, et cetera, et cetera. This, from a teenager, should not be a surprise. Both the average teenager, right, who goes through a so-called stage, but also in particular the teenager or young adult with particular vulnerability who is now into substances, and then reciprocally the effect of substances on executive function, the effect of substances on emotion dysregulation. So it's a positive feedback loop that leads to more difficulties. All right, so there's our little chapter on vulnerability. Now I want to talk to you a little bit about cannabis. What's the big fuss anyway, right? Is it a drug? No, it's a medicine. No, it's a recreational product, right? Everybody uses it. Well, no, not everybody. Here are just some pictures that illustrate part of the point. You see Snoop Dogg as a cultural icon for the celebration of cannabis use. You see edibles, you see syrups, you see big blunts with high-potency cannabis stuffed into cigar wrappers. You see a young lady smoking at doses that are now characteristic of some of the doses that young people are into. This is not your grandfather's reefer from the 1920s, right? This is high-potency, high-concentration THC brought to you by the same miracles of hydroponic agricultural breeding that bring you high-protein miracle rice. Well, we can get THC up to incredible levels, and we can smoke it in big, fat blunts like these 2 young ladies here, and that's a different substance. So we got to also think about the pharmacological effect as being very high potency. What are the toxicities? What are the problems? Well, it isn't that cannabis is immoral, right? We get construed as having this puritanical, prudish view. No, it's not. No more than alcohol is immoral. It's that although most people don't get into trouble, some people get into trouble, and the vulnerable populations are, among others, young people, people with psychiatric illness, people with other substance use disorders, but today we're focused on youth. Youth, young people, get into trouble and have increasing vulnerability compared to older people, and they have increasing rates of loss of control compared to older people. There are acute consequences of intoxication, like motor vehicle crashes, and there are psychiatric consequences of use. The one that we know the most about in terms of its impact and effect size is psychosis. I won't show you the data today, we don't have time, but this has now been replicated again and again over the past decade, in which prospective studies show what is almost essentially a causal link. We haven't done it through randomized exposure, but almost that good. That exposure to cannabis leads to increased rates of psychosis, some of it self-resolving, some of it not self-resolving, with hazard ratios somewhere in the range of 2 to 6, depending on frequency and potency. So imagine that, the use of cannabis increasing the risk of developing a psychotic disorder by 6-fold. Now, again, it's still the minority. I don't mean to exaggerate, one puff and you get schizophrenia. It's not like that. And I don't expect that that's going to dissuade 15-year-olds from experimentation any more than telling them that they might get lung cancer in 50 years might dissuade them from trying their first cigarette. But it should be impactful to us in terms of the clarity of the public health message of the health impairment. Depression and anxiety is not as clear, and the effect sizes are smaller, but although people subjectively say, oh no, cannabis reduces my anxiety, cannabis reduces my depression, in fact, the data say otherwise, and over time, regular use of cannabis seems to increase depression and anxiety. And there are at least several good studies now that show that there is probably a cumulative and lingering cognitive impairment with significant cannabis use, not with casual use, but with significant and regular casual use, with significant and regular cannabis use. One study showing that adolescent onset cannabis use over the course of a couple of decades could lead to as many as an 8-point IQ loss over that time. I don't know about you, I need all the points I can get. I can't afford 8 points. But most importantly, the issue with cannabis for young people is the risk of progression to cannabis use disorders, to loss of control, and as well progression to other substance use disorders. And just a little bit of data around that. Well, here's first of all the notion that perception of risk and use are reciprocally related. So the more people, and young people in particular, think that there is harm, the less they use. The less they think there is harm, the more they use. I can't tell you if it's chicken or egg, if using leads to less perception of risk or less perception of risk leads to more use. But either way, here is this trend. And certainly now we are in an era of low perceived risk of harm because, again, the same factors I've talked about, everybody's doing it. It's a medicine. It's legal in all the states and will be, et cetera. That's problematic. But if we say, and here's just a picture of the culture again, if we say that experimentation is normative, what about extreme use? Here's prevalence of daily use among 12th, 10th, and 8th graders. So here we have 6% of 12th graders are daily cannabis users. I guess the good news is in 8th grade, it's only 1.2%. But the bad news is 1.2% of 8th graders are using cannabis daily. And so I think most people would not argue that that's just casual recreational use. And here's some data. This is, I think, an Australian study looking at a large cohort. First of all, we look at the conditional risk of developing a use disorder. So that means that of people who use, how many will develop loss of control and problems? In adults, it's probably very close to the same number as for alcohol, in the range of 10 to 20%. Maybe let's split the difference, call it 15. But in adolescents, it's probably as high as 40 or 50%. Again, it's not 100%, but still, that's a huge increase. And if you look at risk conferred by daily use of cannabis under the age of 17, we see an 18-fold risk, an odds ratio of 18 in persistent cannabis dependence into adulthood, 3-fold increase in rates of high school dropout, 8-fold increase of progression to the use of other substances, other drugs, and a 7-fold increase in the rate of suicide attempts. So just one snapshot of the impact in the progression to use disorders. So again, it's not that we are puritanical prohibitionists and nobody should ever touch it. It's problem use. Problem use is the minority, but it is a significant minority and much increased for young people. The more people have access, the more young people are able to use it all. As the denominator goes up with the same rate of conditional use, the numerator, the number affected will also go up. We also see decreased perception of harm as the culture shifts, and that is a big problem for our young people. And if you think about where we've been before, right, we've had the same problem with recreational commercialization with alcohol. Oh no, don't worry, Dr. Fishman, we're not going to let anybody under 21 touch the stuff. We are very careful about carding, and our medicalization and commercialization make sure that young people don't get it. Yeah, how's that working for you with alcohol? And by analogy, medicalization, we all know about the problem of the unintended consequences of increased access to prescription opioids for analgesia in the U.S. and where that's gotten us. So again, these are the reasons we have to be concerned. This kind of historic exaggeration, it's the devil's weed, one puff, you'll kill your grandmother, that doesn't help anybody. And we have to instead move to a medical conversation about harm, about the facts, without this kind of crazy over-dramatization. But I tell you what, we are swimming upstream given the culture and future marketing. And when the boys and girls on Wall Street get a hold of this stuff, like tobacco, like alcohol, watch out, right? On a hot summer day, who wouldn't want strawberry cannabis ice cream? And so we got to just contend with how do we counter that message among young people, the same as we've had to contend with Joe Camel, right? All right, so I want to spend most of the rest of our time talking about clinical approaches. When a young person comes into your practice and you're concerned about substances, they're not there for a substance problem. We're talking about you're involved in their general care, you're talking to their parents about their general risk behaviors. And so they're not walking in saying, listen, doc, I woke up this morning and realized I'm out of control. I have a problem. I want your help. You know, that's what they say about their acne, right? But they are pre-contemplative about their cannabis use, if not pre-contemplative. And the notion is, how do you move the ball down the field in terms of their self-recognition of problem and shaping behavior? Well, I think the way that we want to approach this is not with the expectation that we're going to move people from pre-contemplation to action in one fell swoop. It is a marathon, not a sprint. The kids are not going to see it our way right away. They're going to think that we are barking up the wrong tree, they don't have problems, that it's not them, that they can handle it, that everybody else is doing it. All of those things that cannabis isn't a problem, isn't a drug anyway, all the things that you fully expect. So the way to approach this is in a more indirect, relationship-building, motivational enhancement way, using the principles of motivational interviewing that I'm sure you may be familiar with. And just to give you some script, some language, this indirect end-around way. Well, I know you say that it's not a problem for you and you can handle it and you've never been in trouble, but let me just ask you about your friends or other people. Do you know anybody who uses too much or who has been in trouble or who is impaired, who you would call having a problem, right? And that frames the conversation. Now it's not quite as personal. They're not defensive, but you're on the page as having a conversation about there is such a thing as too much. And can we think of what you've seen in your life as an example of problem use and how we define that and what are the metrics? All right, I know you disagree with me, and maybe you disagree with your parents that it's a problem, but can you articulate why we might think about it that way? Why would I wonder or worry that cannabis use in someone your age, or in you in particular, might be a problem. And that's a very important developmental assignment, getting a kid to step outside themselves, be able to articulate somebody else's point of view, and once again, start to establish the frame of the conversation, even if we accept that they don't agree, and that's okay. Well, let's talk about the pros and cons for you, right? Everything's got some pros and cons, and you notice I lead with pros. Why would I lead with pros if I think it's a con? Well, because people wouldn't use intoxicants if they didn't like them. There's obviously something good about it, something that they like about it, something that they're getting about it. And by acknowledging that, you gain credibility. I'm not just an old so-and-so fuddy-duddy graybeard who doesn't understand. I certainly am that, but I'm not only that. And so let's have a conversation about what you like about it. But can you think of anything that's con? No, I can't think of it. It's all good. All right, well, what are some of the things that someone else might think it's a con? And what would it take for it to become a con or a problem? So what would be the evidence, in your view, that it had become too much? What would be the evidence, in your view, that you had crossed a line? Would it be your grades falling? Would it be smoking before school instead of after school? Would it be smoking every day instead of every other day? Would it be smoking 3 times a week instead of 2 times a week? Would it be smoking alone instead of only when you're at a party? I don't know. Whatever the line is in the pageant of their own life that they can conjecture, no, that's a shore too far. That would be the line. But I'm on this side of the line, so I'm okay, Jack. Well, you say you could stop any time. Well, that's fine. Can you really? Would you be willing to see what it's like? You say that it's no big deal either to stop, and you say that it's not affecting you or impairing you. Give it a try. Indulge me. Try to not use for 3 weeks. Come back and tell me what it's like. We'll compare notes. You'll see what it's like. And that gives you a number of reference points. One is, if they come back and they didn't stop, well, how come you didn't stop? I thought you said you were going to try. Was it really harder than you thought? They might come back and say, I stopped and it was no better. In fact, it was worse. All right, but at least you're having a conversation. And that is the main point, starting the conversation. Can we get you to come back and see how it's going? You may disagree with me, but I appreciate your honesty. It's not helpful for me for you to just nod and say, okay, doctor, I agree. It's bad for me. I'll never use again. No, don't tell me just what I want to hear. Tell me the truth. Tell me why you disagree with me. Tell me why you think it's helpful or whatever. But let's have a conversation. I respect your honesty. I respect your braveness for being able to have this direct conversation. Can we keep it going? And let's make this a longitudinal exploration. And if I think it's problem enough, will you get a second opinion? Will you go see a specialist? And we'll talk a little bit about how to kind of craft referrals. But 95% is showing up. 95% is having the conversation. 95% is generating engagement around these interactions because, as I say, it's a marathon, not a sprint. The other thing that is so important is, in general medical practice, to think about the comorbidities that are common and typical of kids that are into increasingly large amounts of substance use, right? Sexual risk behaviors and STIs, pregnancy prevention are important health needs, reproductive health needs around these patients, thinking about smoking cessation and what possibilities there is of exacerbation of reactive airways disease, both from tobacco and from cannabis smoking. Traumatic injuries during intoxication go together. And by the way, if that does happen to your patients and you can show them that there's a link between falling off a ladder, falling off your bicycle, having a car crash, and using, that can be very instructive. And on the mental health side, the link to depression and anxiety is very real. And when thinking about the risks to patients who are using substances in addition to taking prescription stimulants for ADHD, the idea of monitoring for safe adherence is very, very important. So what about talking to parents? Especially important for younger adolescents, but I think really important and underrated even for older adolescents and even young adults. After all, most of these youngsters, whether they're 15 or they're 25, are relying on the support of caring adults, usually their parents, but it could be grandparents, extended family, other caregivers. And there is care and support and the opportunity for leverage from those adults. And in all sorts of ways, they are already relying on those adults. They say, well, listen, I'm all grown up. I'm 18. I've got this. It's nobody's business. But not really. So being able to frame that, this is your private treatment. You are my patient. I will try to keep things confidential. That is mitigated by my judgment of imminent risk. So you should know if I'm worried about you, I am going to push the panic button, but I'm not going to do it behind your back. So I need to know the whole story. I promise to keep things private unless we discuss them. I'd rather you reveal them than me reveal them. I'm not a snitch. I'm just trying to help you with open communication and persuade you that they're going to find out what you're into anyway. I know you think you're keeping the world's tightest secret, but it always comes out, and it's so much better if it comes from you and you get parent points for being straight and being honest and problem solving rather than getting busted. Well, I'll be in trouble, they'll kill me. No, I'm going to run interference. I've done this before. Let's talk to them. And by the way, if you can show them how you can do that with their parents in their room, and especially if their parents are a bit naggy and intrusive, and you can set some limits on the parents about privacy and about reasonableness in front of them, boy, that gets you huge points, right, as being in their corner. And so you can kind of get credibility and engagement that way. And you've got to make your own judgment about what's the point of risk and urgency. If they're experimenting with beer and cannabis and they're not in a boatload of trouble, then there's no big emergency, and you've got time to have the conversation and get to yes in terms of consent for disclosure and having them disclose. You know, if on the other hand, they've just had 3 near-fatal overdoses and been in the ED getting resuscitated with Narcan in the past week, then you may say, listen, we got to discuss it today no matter what consent you give me because there's imminent risk. You know, so these are judgment issues. Those were 2 extreme examples. Most things are gray in between, but you get the picture. Talking to parents is tricky, and you want to make sure that they understand the limits of confidentiality, but also that you're going to be trying to pursue confidentiality, that they're not going to hear all the gory details and that they're going to have to trust you, that you'll tell them only what they need to know and that only when there's urgency, but that the goal is to include them. And families come in all shapes and sizes. Some parents will be, oh yeah, whatever, and they'll minimize impairment and they'll be over permissive, and they're the parents that are giving the kids alcohol and you know, throwing parties and saying, oh, we smoked cannabis when we were young and it didn't kill me, so that's fine for them. And then on the other extreme, there'll be some parents that are alarmist and punitive and over-intrusive, and you got to figure them out a little bit and learn to work with their styles and try to shape both extremes to somewhere in the middle. You want to show them, with both the kid and them in the room, some modeling behavior, how to have the conversations, how to talk through some of these issues, to coach them that they shouldn't expect big epiphanies of insight from the kids. When you say, oh, cannabis is dangerous, tobacco is dangerous, alcohol is dangerous, don't expect the scales to fall from their eyes and them to have an aha moment. That's not how young people learn. It's gradual, and they've got to pick their battles, right? I can't tell you how many times, I'm jumping ahead a little bit to talk about high severity, high chronicity opioid use, but I can't tell you how many times I've had to have the conversation with the parents of young people who are using injection heroin every day, and they want to argue with me, how come I can't make them clean their room? Wait a minute. You got to prioritize. You can only have one, at most 2 goals here. Is it going to be cleaning their room, or is it going to be injection heroin? I don't know. You pick. The other issue that is tricky and comes up is the question of parental use, household use, right? And young people are mimics, you know that, and they're going to do more what we do, not what we say. And the normalization and the permissiveness of household intoxicant use is actually a very big deal. You may even expect not just recreational level use in the household, but problem level use, addiction level use. But the parents didn't necessarily come looking for your advice about their behavior. I brought my kid. This is my kid's treatment. How dare you? What are you implying about me, doctor? You don't know me. This wasn't supposed to be about me. So you gotta tread lightly on that. And what I tend to do is try to do an end around with a universal precautions spiel, which is, listen, I don't know you that well. I don't know how things go in your house. I'm not saying anything about you, but sometimes, and in some households, there is normal recreational alcohol use, maybe even cannabis use, and I'm not making a judgment. I just want you to know that if we're trying to reduce the use in your kid, kids are mimics, kids will do what you do, not what they say, and I know I'm asking you a lot, and I know it's a great burden, and maybe it's too much to ask, but at least for now, substance-free households have been shown to be helpful in producing substance-free kids. So what about just a temporary no use in the house policy just to model that behavior? And sometimes that works, and sometimes it blows up in your face and backfires, but it's one approach. I think it's important, again, I can't reiterate this enough, to think about this as a longitudinal process. Each visit is continuing the conversation, and it helps to look back at what the young person said about a line they might not cross, or what a metric or a definition for problem use might be, right? How's it been going since last visit? What do you think about what we talked about? Did you try to stop? If you didn't, well, how much have you been using? Did you try to even cut down? No, you didn't? Okay. But now you say you're using before school? Oh, I thought you said it would be a problem if you use before school. Well, I changed my mind. Actually, it helps me do my math homework, and that's why I use before school. Okay, well, now what would be the new line that you wouldn't cross? But you can see that we're continuing to explore and to try to get the young person to set their own limits in their own narrative. And again, asking, well, can we get help from your parents? What would be the role that they could play? No, I know you don't want your mom to nag at you. No, I know you don't want to be in trouble. Well, what could they do that would be helpful? Urine drug testing is, in my view, a critical and underused tool. Now, if patients are telling you they're using, then it isn't necessary that urine drug testing will add much. But they may say, I'm using cannabis, but that's all I'm using, and not tell you about the pills or about the cocaine or about other things. And if so, if you suspect, then it's a useful diagnostic. If you're monitoring and you're concerned that they're not telling you the truth, it's a useful tool for assessment and monitoring. You don't want to put too much in it. A positive drug test does not equal problem use, just as a negative drug test does not equal resolution of problem use. Like any lab test, it's just one data point. And I think it's helpful to try to normalize it as routine. I'm not trying to get you in trouble. I'm not saying you're lying. I'm not trying to second guess you. This is just a thing we do. It's like any test. We get blood tests. We get urine tests. It's what we do around here. And it medicalizes the conversation. It normalizes the practice. It takes a little practice, about what's your spiel, what's your narrative. But I think certainly in specialty care, like I do, we do it every visit or every other visit or very often. I'm not advocating for that. But I think to make it a standard tool in your tool chest and figure out how you're going to sell it and detoxify it, pardon the pun, I think is a valuable thing. So to summarize all of this, healthcare providers, and especially in primary care, we have enormous impact on patients and families. And so I'm not making the Pollyannish naive claim that one word from you and they will do exactly what you say. Of course not. But your voice lingers in their heads, just as their parents' voice lingers in their head, even if they don't follow all the instructions. And as a healthcare professional, you guys have stature and authority and persuasiveness more than you realize, or maybe you realize it, I hope you do, but it's so important that you keep on message and that you stay consistent and that you don't try to make excuses. They can agree to disagree. That's fine. I use that terminology all the time. I say, well, we'll agree to disagree. But I just want you to know that as your doctor, this is my view. Make no mistake, you can do something else. You can disagree, but that doesn't change my mind. So let's just, but again, I appreciate your being honest about it. Let's keep talking about it. So the clear standard is that any intoxicant use at all is unhealthy for adolescents. Let that percolate for a minute. Sit that in. That may sound extreme to you. That may sound like it flies in the face of our normative expectation that, sure, adolescents will experiment. Of course, many of them, 60% was the number I showed you, will have lifetime use. But that is risky. The best amount is 0. Does that mean that I'm mad at you if yours is more than 0? No. Does that mean I'll cut your head off or your parents will cut your head off? No. But I want the message to be clear. Intoxicant use is unhealthy for adolescents. Now, if you've used, let's talk about it. And then our goal is to examine that and see what your risks are for progression and talk about where you are in that trajectory and that progression of use. Is it problem? Is it severe problem? Is it non-problem? But at least to be clear about the message. Delay is an important thing. I'm not saying you can never have a beer, but the longer you delay, the better. And although we will expect most young adults to have sampled, it is again the same message of the unhealthy risk of loss of control and how easy it is to not notice that you're using too much. So this kind of longitudinal approach where follow-up and ongoing conversation holds up a mirror of dynamic change to the person, both in terms of their positive progression and their negative progression, and helps them get a better view of themselves from your perspective as a healthcare professional, I think is the way to go. Now, sometimes you're going to find that the young person is at a level of severity that they need specialty care, that you can't manage it in a general medical setting. That will certainly happen. It will be the minority, but it will certainly happen. So what's your cut point? Where are you thinking you need help? And develop a network of local resources. Know who you can call, just as you have an orthopedist that you sometimes call, that you know an endocrinologist that you sometimes call, who's an addiction medicine person, who's running an addiction medicine program, what's the local rehab, what's the local IOP. And I'll tell you, sure, you want quality, but even okay is better than nothing. And the message of optimism, and I know we've got to wrap up in just a couple of minutes, is that the sooner we intervene, the quicker they get better, right? So here is the flip side of the graph I showed you before where I said the earlier they use, the slower they get better. Here is the same stratification, but now in terms of how long between first use and first treatment. And you can see that having treatment within 0 to 9 years confers 57% sooner good outcome as 1 or more years of absence in the community compared to waiting 20 or more years. So what you do is impactful. We don't have time this time to talk about opioids. I'm sorry. The bottom line there is that for the higher severity youngsters in your practice who are using opioids, and it will be the minority, get comfortable with recommending, or if you want to be bold, even prescribing yourself medications for opioid use disorder, and that's buprenorphine and extended release naltrexone primarily, or find a referral source where you can have specialists who you can refer to who will do that. And I'll quit now, have a few minutes for some questions as we wrap up. I hope that's been helpful. I don't know if we're going to do it through the chat box or through unmuting people.
Thank you, Dr. Fishman. If it's okay, I will take our attention to the chat. A couple comments and questions have come in already. If folks have questions, feel free to enter them in the chat. There's a comment, Susan pointed out you were making some great points about media and how kind of relevant social media and what a strong influence that has now on our adolescents. And then a question from Heather. Dr. Fishman, how do we address clinical risk, but also acknowledge the systemic issues with the war on drugs and criminalization of cannabis? She says, I know legalization creates issues with some young people and adults thinking there isn't risk, but I think it is important because the war on drugs targeted many communities of color unjustly.
Oh, absolutely. No, that's a very important point. And I think there's a big difference between criminalization and restriction of access. So the errors and mistakes and injustices of the past, and we're not totally out of the bag, right? We're still perpetrating a lot of those injustices. We should be done with that. We should dismiss that. Giving people hard time in federal lockup for cannabis, did that ever help anybody? No, that's ridiculous. The economic and racial disparities that we know all too well, say between powdered cocaine and crack cocaine, et cetera, make no sense. Those harm people. But having said that, we can have our cake and eat it too. We can be more just, less punitive, decriminalize, and still be clear about the social prescription. For example, we do that with traffic laws. We don't give people hard federal time for running a red light, but we are crystal clear that it's bad for you and bad for your neighbors to run a red light. Don't do it. It's against the law. It's unhealthy. I think we can find a nuanced way to do that. The question is, what about the civil libertarian issue about access for mature adults who wish to have non-problem, non-loss of control recreational use? It's essentially the alcohol question, right? How do you allow for those people that don't have loss of control the right to have a glass of wine with dinner or a beer at a football game and not be out of control, but still balance the risk to those that are vulnerable? That's a difficult policy question. And I still think, though, that alcohol's out of the bag in the sense that we've got 10,000 years of normative use and cultural sanction and all the like. And we also have rates of use in this country, that exceed 80% of the population have lifetime alcohol use. But that's not true for cannabis. It's a minority issue. I think, and this is a bit of hand waving, I'm not a lawyer, I think we can say it is proscribed. It shouldn't be allowed. And those mature adults who want to use recreationally can find a way to do so in ways that don't end them up in deep trouble in a punitive way. But we have to make a balance. What about the risk to the vulnerable versus the rights of the majority to, expose themselves to buyer beware risks? And we do that with motorcycle helmet laws. We've decided that the protection of the vulnerable is more important than the right of people to feel free with the wind blowing in their hair. Difficult and vexing policy questions, but you can see that I come out on the side of trying to protect the vulnerable. But I do take your point. We don't have to do it by repeating the sins of the past with punitive and excessive decriminalization. That's harmful. We need to stop that, and hopefully are on track to do so.
Dr. Fishman, there are a couple more questions. I will just mention that it is 1:30. Jamie has added some specific details for folks who are going to close out to be sure you get your credits and complete the evaluation that's required to do so. I'll make just another kind of program comment that if you are looking for guidance around providing treatment to your patients and you have a question related to access to resource and referral, or perhaps you want to provide medication-based treatment and you're looking to get your waiver, or you have questions about providing care in your practice, BHIPP and MACS are both resources available to you. So if you have questions about how those services work, want to get training, or want technical assistance, if you're a provider that has recently been waivered or is looking to get waivered, please call Max or BHIPP. We're happy to just answer general questions or get you connected with resources or help in the treatment of your patients. So just as we're now at 1:30, I want to mention that.
No,
Dr.
good. And
Fishman,
let me make two offers. One, if you guys want me to come back another time, I was long-winded and ran off at the mouth too much today, but if in the future you want me to dedicate another one of these solely to opioid use disorder treatment in youth, I'm happy to do that, number one. And number two, I'm happy to have my contact information disseminated, and people can contact me personally for consultative guidance on individual patients. It's something I'm passionate about, happy to help.
That's very generous. That is very generous. And I just was, I know people will probably sign up because they were at 1:30, but if you wanted to respond to any of these questions, we could keep the recording going and it could be on the website.
Sure. I can stay another 15 minutes, yeah.
Okay, we could take a couple more minutes. So let's see. There was a question about, do we have enough access for these children and adolescents to get the care and attention that they need? And perhaps we could combine that with what you might be seeing during the pandemic in terms of substance use or abuse in adolescents. The parentheses here is we're seeing a record number of mental health disorders as primary care providers.
Sure. No, there aren't enough resources. There never are for young people, and that remains a problem. So, you know, cultivating your local resources, trying to find people who will assist, taking on as much as you can within your own practices up to the point that you're comfortable, you know, is the reality. In terms of the pandemic, I don't think we really know the answer to that. I think, as you say, the preliminary data is that mental health symptoms and probably mental health disorders are up. That shouldn't be shocking given known risk factors, the stress, the problems in parents, the economic hardships, the loneliness, the loss of structure and connectedness to peers, you know, all the things that you can imagine, those are known risk factors. So we wouldn't be surprised to see that substance use in youth is up. But we don't really know. There is some preliminary signal in adults that looks like use is up among a subgroup. There probably is convincing data that alcohol consumption is up in the general population, never mind people with loss of control or use disorder, but just that we're all drinking more in quarantine. That data seems to come from retail sales, and it's hard to correct for the corresponding loss of sales in bars and restaurants. So getting the actual lens on what real consumption is like will probably take some more data. But yes, we're all concerned that things are not going in a good direction.
Thank you. I know we've certainly been hearing calls to both the Max and BHIPP phone lines that have us thinking the same thing. It'll be interesting, I think, once data has been collected and reviewed to understand how we can better support adolescents and families. Another question came in specific to PCP use. I'm scrolling here to be sure. It says, what is your take on the use of PCP and how do we help youth see its dangers?
Wow, tough, right? PCP comes and goes I don't know where your patients who are using PCP are. It seems to have a regional pattern like many intoxicants. DC and Prince George's County have long been kind of residual hotbeds of PCP where it's fallen off from the 70s in other places. Again, I don't know where you practice or where your patients live, but that's where I've seen a lot of it. And it has been a trouble in young people. There are no clear and convincing treatments specifically for PCP, either psychosocial treatments or pharmacological treatments, other than general treatment of SUD by the same principles. And I would say that if you can show patients the troubles in the narrative and pageant of their own lives, that's likely the most impactful way in the same kind of motivational enhancement way. Did you end up in the ED? Did you have a fight? Did you get in trouble with the law? Are you in trouble with your parents? Have you stopped going to school? Do your friends think you're wacky when you behave like that. Whatever it is that they could identify as a problem, or if they have peers that are using, are there peers that you think have crossed the line, and have you seen the consequences? But it's a very difficult problem, and the psychiatric consequences, as I'm sure you know, can be devastating in terms of producing agitated delirium, in terms of producing both transient and sometimes permanent psychotic states. Bad news.
This provider added in that she is from Annapolis.
Okay. I didn't know about that being a hub of PCP. Thank you for that.
And then the last comment that I see here, Dr. Fishman, I think maybe you could respond to kind of a comment question, was about the challenge of engaging parents when the patient's an 18-year-old and doesn't want the providers to talk to parents. I know you spoke to this during your presentation, but we did get a comment about that. So I don't know.
Sure. It's a tricky thing. And I think the starting point is to make it a goal. Put it on the table. Think of it explicitly as an aspirational objective, and that will help. That is to say, this isn't an isolated treatment of an autonomous, self-directed, self-guided, wise decision-making grown-up. This is a young person with the typical vulnerabilities who needs that help. How can we try to achieve that? So if that's on the plate, already you'll have more success. I think that you will get some pushback from the young people. And by the way, that's developmentally normative, right? For young people to say, my parents are have a subjective sense of their parents as being over-restrictive, over-intrusive, as nagging, it's none of their business, I got this. That's normative. We want them to gradually value their emerging autonomy with 1 foot in adulthood and 1 foot in childhood. But don't forget, they still have that 1 foot in childhood. So the goal is getting to yes. And that's how I think about it. That is, we're going to get to yes. I'm going to get you to endorse my bringing in as many helpers as I can, your parents being foremost among those, into the conversation. And if you don't say yes today, as long as it's not an emergency, it can be tomorrow, but we're going to get there. It's like green socks or red socks, but not no socks, right? We're going to get to yes, and it's just about how we do that and how we achieve consensus around that. Unless I need to push the panic button, and I always upfront about that. If I have to push the panic button, I'm going to do it. I'll call the cavalry, but up until then, I'm going to want to encourage you in a way that encourages your self-efficacy and your emerging autonomy, but make no mistake, just because you're 18 in one day doesn't mean you have it, and we're going to try to work with that. And you'd be surprised. Yeah, there are some kids who say, if you say one word, I'm a lawyer up on your rear. But I can count on one hand the number of times I've had to fight that fight and not been able to gradually get to some kind of consensus about let's get help. By the way, not only do we talk to other parents, we talk to other healthcare providers. This is maybe another conversation when we talk about high severity, high chronicity opioid addicted youth, but well, yes, I take Xanax. It's prescribed to me. It's the only thing that works. And no, you can't talk to the psychiatrist who prescribes it for me. No deal. No deal. If I'm going to work with you and try to care for your health, it's hard enough with all the information. I need all the information. We're going to collaborate. Well, I forbid you to call. Well, it just depends on my judgment sense of urgency. If I need to do it today because I think it's a matter of imminent harm, I'm going to do it anyway. But I prefer not to do that. I prefer to get to yes, to build consensus. Let's call them together. What are you worried about? How can we manage this? How do you save face? How do I run interference for you? That kind of stuff.
Thank you so much, Dr. Fishman. It looks like we have hit on the comments and questions. I appreciate everyone sticking around for a few extra minutes. I will say, just looking in the chat, We've also heard a lot of positive feedback already and some requests for your offer to come back and talk with us about adolescent opioid use. So we look forward to reaching out and talking with you, hopefully, about those details. So again, thank you, Dr. Fishman, and thank you, everyone, for taking the time to join us this afternoon. Enjoy the rest of your Friday afternoon and the upcoming weekend, and we will see, I hope, a lot of you for our next BHIPP or MAX webinar. Good afternoon.
Great. Thanks, everybody. Hope that's helpful. Talk to you later.
Thank you.